And now, to begin the program, we welcome our moderators, Doctors Peter Glavitsky, Peter Lawrence, and Suman Wasson. Doctors, the screen is yours.
Good afternoon, everyone, and thank you for joining us for the webinar, Translating Guidelines into Practice, Management of Patients with Varicose Veins of the Lower Extremities. Our goal today is to present the latest clinical practice guidelines based on a systematic review and meta-analysis of the available scientific evidence. I am joined today by my co-moderators and co-primary authors of the practice guidelines, Dr. Peter Lawrence, Emeritus Chief of Vascular and Endovascular Surgery and the Ganda Vascular Center at UCLA in Los Angeles, California, and Dr. Suman Wasson, Clinical Professor of Medicine, a vascular medicine physician at the University of North Carolina, Raleigh.
Thank you, Peter. And as you mentioned, our faculty today will cover the latest clinical practice guidelines and will analyze the results of percutaneous venous ablation procedures and compare them to those obtained from compression therapy and open surgery for the treatment of symptomatic varicose veins. The faculty will use a case vignette approach to demonstrate how the recommendations from these clinical practice guidelines can be applied in practice. And you have heard that you will receive a short survey that has to be completed now. Suma?
Thank you, Peter. This session will be helpful in expanding the physician knowledge base and improving clinical confidence and effectiveness in treating patients with varicose veins. The session will address diagnostic evaluation of patients with varicose veins using duplex scanning to confirm pathologic superficial truncal reflux. The session will also cover compression therapy, open surgical and percutaneous endovenous therapies for lower extremity varicosities, including thermal and non-thermal ablations of the great, small, and accessory saphenous veins. The treatment of perforating veins and the concomitant treatment of varicose tributaries with sclerotherapy or mini phlebectomy will also be discussed.
Excuse me, doctors, I would like to ask our attendees to please go ahead and complete that pre-survey now. If they have not yet done so, we will compile the results, compare them to a post-test after the webinar. Thank you.
Okay, well, let's get started. Our first presentation is from Dr. Mark Meissner from the University of Washington in Seattle. Dr. Meissner is the Peter Glavitsky Professor of Venous and Lymphatic Disorders at the University of Washington Medical Center. He is past president of the American Venous Forum and the American Vein and Lymphatic Society, and recent Secretary General of the International Union of Phlebology. Mark's clinical and research interests include acute and chronic venous disease, pelvic venous disorders, and venous reconstructions. He has published over 130 peer-reviewed manuscripts, many on these topics. Dr. Meissner joins us now with a pre-recorded presentation titled Diagnostic Evaluation of Venous Incompetence.
Good evening. My name is Mark Meissner from the University of Washington, and tonight I'm going to be talking about the new guidelines regarding the diagnostic evaluation of venous incompetence. I have no disclosures. We'll start with the case of a 14-year-old girl referred with a 1-year history of right lower extremity heaviness and discomfort. On physical examination, she had no visible varicose veins, no edema, and no other signs of venous disease. Her family history was negative for venous disease. She'd undergone an outside duplex examination, which on the report suggested that the exam was done in either a standing or reverse Trendelenburg position, although on questioning the patient and her family, it was clearly done in the supine position and demonstrated reflux throughout the deep venous system, as well as the great saphenous vein on the right, and reflux in the femoral vein and in the great saphenous vein in the calf on the left. The outside facility had recommended ablation of the right great saphenous vein, and her family now brings her in for a second opinion. We repeated the duplex study in the standing position using a distal cuff deflation method, which in contrast to the outside study demonstrated no reflux in the common femoral vein, the femoral vein, or the great saphenous vein. So what went wrong here? Duplex ultrasound is clearly the diagnostic gold standard for the detection of valvular incompetence, where reflux is defined as retrograde flow in response to a provocative maneuver. However, from a diagnostic standpoint, the criteria depend on a number of factors, including the defined cut point for the definition of pathological reflux, the provocative maneuver utilized, and patient position, supine, reverse Trendelenburg, or standing. To understand what went wrong, we must have some understanding of the mechanism of valve closure. With normal antegrade flow, the venous valves are open, as shown here. Valve closure is initiated by reversal of the normal transvalvular pressure gradient. As this pressure gradient gradually increases, there is initially a short period of retrograde flow or reflux until the gradient becomes sufficient to cause valve closure. More than simply cessation of antegrade flow, valve closure requires retrograde flow of sufficient velocity to completely coapt the cusps. The velocity required to ensure complete valve closure appears to be 30 centimeters per second. At velocities less than 30 centimeters per second, reverse flow may persist for longer intervals, even in the presence of competent valves. The determination of valvular incompetence therefore requires that pathologic retrograde reflux be demonstrated in response to maneuvers that consistently generate an adequate reverse flow velocity. Such retrograde flow velocities are usually achieved in the upright position, although may be inadequate in the supine position. Standardized testing using pneumatic cuffs is the most technologist-friendly and most reproducible way of detecting reflux. This scattergram illustrates the segmental results in the 30 normal extremities examined by Van Bevelen using a distal cuff deflation method designed to produce retrograde velocities greater than 30 centimeters per second. Using this method, 95% of normal valves will close in less than 0.5 seconds, allowing reflux to be quantified. Nikos Labropoulos similarly evaluated a larger group of both patients and controls using a standing cuff deflation method. For all segments examined, mean reflux times in the superficial perforator and deep veins of patients were significantly longer than those of controls. Based upon this data, optimal reflux duration cut points for distinguishing patients from controls were 500 milliseconds for the superficial veins, greater than 1,000 milliseconds for the femoral and popliteal veins, and greater than 350 milliseconds for the perforating veins. He also found that reflux assessment in the supine position leads to both false positives and false negatives. Among 10 patients evaluated in both positions, reflux was falsely positive in 12% of patients in the supine position and was absent, that is, falsely negative, in 7% of segments with reflux in the standing position. False negatives are presumably related to a lack of dependent venodilation in the supine position, while false positives presumably result from failure to generate an adequate reverse flow velocity. False positives are likely a much bigger problem than false negatives in the supine position, as was the case in this young girl. The INVEST study investigated the repeatability of duplex ultrasound for the determination of reflux in 17 healthy volunteers and 57 patients with chronic venous disease. Study parameters, including time of day, position, and provocative maneuvers, were varied in the evaluation by a single technologist. On average, reflux times were significantly shorter in the standing compared to the supine position. Repeatability, as measured in seconds, was better in the standing than in the supine position, and the best repeatability was achieved in the standing position in the morning. And the new multi-societal guidelines endorse duplex scanning as the diagnostic test of choice for venous reflux as a grade 1B recommendation. Further, as implementation guidelines, they establish diagnostic thresholds for defining reflux of greater than 500 milliseconds in the superficial veins, greater than 1 second in the common femoral, and popliteal veins, and in combination with a diameter of greater than 3.5 millimeters, reflux duration of greater than 500 milliseconds in the perforating veins. Furthermore, evaluation in the standing position is recommended whenever possible, as provocative maneuver, either a Valsalva's maneuver or distal compression, are recommended proximally, and distal compression for the more distal segments. The examination should also include measurement of spectral Doppler waveforms using calipers. The guidelines also recommend that diameter measurements be made with the leg in a dependent position. However, it is important to note that isolated diameter measurements poorly correlate with the degree to which a patient's quality of life is impaired or with improvement after superficial venous intervention. For example, in this systematic review of 11 studies evaluating the relationship between saphenous vein diameter, clinical severity, and health-related quality of life, all 8 studies evaluating SEEP found a correlation between vein diameter and C-class. Similarly, among the 5 studies evaluating VCSS, 4 found a correlation, although often weak, between vein diameter and VCSS. However, none of the 4 studies evaluating a variety of quality of life instruments found any relationship between vein diameter and quality of life. As chronic venous disease is most often a quality of life disease, the authors concluded that using vein diameters as a surrogate measure to limit access to care is inappropriate and ineffective. So to return to our 14-year-old patient, in conclusion, duplex ultrasound is the gold standard for the diagnosis of venous reflux, but it must be performed and interpreted correctly, and by itself is not a license to intervene. The 2022 multi-societal guidelines have been a paradigm of collaboration and have established diagnostic thresholds of greater than 500 milliseconds for the superficial veins, perforators, deep femoral and tibial veins, and greater than 1,000 milliseconds for the common femoral, and popliteal veins. As examination in the supine position is less reproducible and may be associated with both false positive and false negatives, the examination should be performed in the upright position whenever possible. And lastly, the duplex examination provides invaluable information, but is not a license to intervene and must be interpreted in the context of the clinical presentation. Thank you very much for the opportunity to participate and for listening tonight.
Thanks very much, Dr. Meissner, for clarifying our understanding of the principles of venous reflux. Our next video is being presented by Andrea Obi from the University of Michigan. Dr. Obi is an assistant professor of vascular surgery and has a research interest in venous and other types of thrombosis, and her laboratory focuses on defining the role of the immune system in acute deep vein thrombosis and its sequelae. She also has a very strong clinical interest in alternatives for treating varicose veins. And today she's going to talk with us about high ligation and surgical stripping versus endovenous ablation. We now will hear from Andrea Obi.
Thank you for the opportunity to give this update. These are my disclosures and none are relevant to the talk at hand. Let's start with a patient case. This is a 42-year-old male who reported to our clinic after 3 years of compression therapy. He had aching, pain, and heaviness over his right medial calf, and you can see the large varicosities here, and then you can see this suprafascial GSV up in the thigh. This was only slightly relieved by compression, and he had a strenuous job as a dock worker, and this interfered with his ability to do this work. He underwent duplex ultrasonography and was found to have a valve closure time in the GSV of greater than 500 milliseconds from the junction all the way down to the mid-cap. His VCSS score was 9. So how should we approach this patient? First, let's talk about the data regarding compression therapy compared to high ligation and stripping for the treatment of symptomatic saphenous reflux. The question of which one of these was superior was addressed in several randomized trials. In the reactive trial, 246 patients were randomized to receive compression therapy compared to high ligation and stripping. Of those that underwent compression therapy, they're found to have worse quality of life and worse symptoms at the completion of the trial. In another randomized control trial of 153 patients undergoing compression or surgical therapy of their C2 disease, patients undergoing compression therapy alone were found to have worse VCSS scores and worse health-related quality of life outcomes, as highlighted over here by the Aberdeen score at 2 years compared to those who underwent surgical therapy. Finally, in a recent systematic review, compression stockings were found to be the least cost-effective option as a long-term treatment option for patients with varicose veins. But we know that other options exist for the treatment of axial reflux. Beyond surgical high ligation and stripping, there's a host of endovenous therapy options. They can be grouped into 2 cohorts, a thermal cohort, including radiofrequency ablation and endovenous laser ablation, and non-thermal, including chemical techniques such as cyanoacrylate and foam, and mechanical chemical techniques such as MOCA. And the difference between these 2 groups would be highlighted by Dr. Hignorani in an upcoming talk. But when we evaluate these different techniques, how do we look at their outcomes? Well, first and foremost, one of the ways to evaluate them is by looking at the anatomic closure outcomes. And for instance, in the CLASS randomized control trial published in the New England Journal of Medicine in 2019, what was found was that high ligation and stripping and endovenous laser ablation, which is a thermal technique, had very similar anatomic closure rates over a 5-year period. Both of these were superior to ultrasound-guided foam sclerotherapy. So if these two have similar anatomic closure rates, how do we decide which one of these is the superior therapy for our patients? Well, let's turn to looking at several of these outcomes, including the early outcomes of return to normal activity and generic and disease-specific quality of life in our patients. So when we compare high ligation and stripping to endovenous laser ablation in 30 randomized controlled trials and 16 observational studies, what we can find is that high ligation and stripping is associated with a decreased likelihood of being pain-free early in the postoperative period and is associated with an increased need for analgesia. When we look at high ligation stripping compared to RFA, and this is long-term data from the EVOLVE study, which is an early randomized controlled trial of about 85 patients, randomizing them to receive one of these two therapies, what we find is that patients who undergo radiofrequency ablation have an earlier return to work by nearly 3 days and are much more likely to return to normal routine activities within 1 day. However, we know that contraindications to endovenous procedures exist, and this can exist in the setting of GSV anatomy that is aneurysmal, tortuous, or as in the case I just showed, superficial and or superficial. Also, it can occur that we don't have available equipment or expertise to perform endovenous procedures. In these settings, high ligation and stripping is a safe and effective procedure. There is potentially a higher recurrence risk associated with high ligation and stripping. This was highlighted in the recent meta-analysis. However, there's overall excellent mid and long-term results that have been published in multiple randomized control trials for this technique. And indeed, for the patient that I just showed with that superficial GSV, that is the treatment that we offered. What about this case? This is a 41-year-old female with C2 disease. You can see from the picture that she has painful thigh and lateral knee and calf varicosities, which became worse after her pregnancy, and she also suffered an episode of thrombophlebitis. Thigh-high stockings were too difficult for her to use on a daily basis, and knee-high stockings failed to control her symptoms. She underwent duplex ultrasonography, and the anterior accessory saphenous vein was found to be the source of her varicosities. The valve closure time was 3,300 milliseconds. So how do we approach this patient? Well, we know that anterior accessory saphenous vein reflux alone or in combination with GSV reflux often contributes to varicosities. And indeed, the anterior accessory saphenous vein is a common source of recurrent varicosities after isolated GSV treatment. But we don't have as high quality randomized controlled trial data with regards to the specific vein. What we do know is that in retrospective studies and observational studies that endovenous therapies of the anterior accessory saphenous vein seem to have similar outcomes to patients with GSV reflux. And you can see the results on one of the trials highlighted here. What do we mean by similar outcomes? Number one, excellent technical success. Number two, low complications. And number three, similar rates of improvement in quality of life scores and venous clinical severity scores. What about the small saphenous vein? How does the data differ here? Well, we know from meta-analysis, including 5 randomized control trials and 44 observational trials, that high ligation and stripping seems to have a slightly lower anatomic success rate compared to the endothermal techniques of EVLA and RFA, and a higher risk of paresthesias, likely due to the proximity of the sural nerve to the small saphenous vein. What we don't have is high quality data comparing high ligation and stripping to non-thermal techniques. We know that the initial data seems to be promising. For instance, cyanoacrylate closure at 2 years is 96%, and in these patients, there was 0 incidence of sural nerve injury. And in another retrospective study comparing high ligation and stripping to MOCA, patients who underwent MOCA therapy had earlier return to work and a 0% incidence of paresthesia compared to 3.4% in patients undergoing high ligation and stripping. So in summary, I think we can say the following from this data: that high ligation and stripping can be the preferred technique if anatomic, operator, or equipment constraints really preclude the use of endovenous ablation techniques. And endovenous ablation techniques are going to be preferred in a large majority of patients with GSV reflux in suitable anatomy, primarily due to less pain, morbidity, and earlier return to work compared to high ligation and stripping, and for the same reasons is preferred in the treatment of small saphenous, anterior accessory saphenous, and posterior accessory saphenous reflux. Thank you.
Thank you, Dr. Obi. As a reminder to our attendees, please use the Q&A button at the bottom of your screen to submit your questions at any time for any of our presenters who are very happy to answer those questions. Next, we'll hear from Dr. Anil Hingorani from New York University Langone in Brooklyn. Dr. Hingorani is a board-certified vascular surgeon at the Vascular Institute of New York and has a very broad range of experience in diagnosing and treating vascular conditions, with his specialties in vascular access, varicose veins, arterial disease, carotid angioplasty and stent, aortic aneurysm, and vein disorders. Dr. Hingorani joins us now with a presentation titled Thermal Ablation versus Non-Thermal Ablation of Saphenous Veins.
Hi, my name is Anil Hingorani. I'm a vascular surgeon here in Brooklyn, New York. And we're going to be looking over some of the data, looking at thermal ablations and non-thermal ablations. We have no relevant disclosures. So we had a 48-year-old female who came into our office complaining of painful left lower extremity varicose veins for 5 years, and the pain's been worsening. She had tried stockings, but without relief. She works as a teacher, and this is worse with working. She has no prior history of DVT. And on duplex, her greater saphenous vein ranges from 8 to 5 millimeters in the left thigh, with reflux times of greater than 500 milliseconds. She wants to discuss her options for treatment, and she's looked up some information online, and she wants to discuss thermal and non-thermal techniques. So there are basically two types of thermal techniques with RFA and EVLA. And there are three basic types of non-thermal techniques with cyanoacrylate, MoCA, and foam. So some of the data looking over cyanoacrylate has suggested that with quality of life, cyanoacrylate versus endothermal ablation, there's really no statistical difference, especially later on after 1 to 5 years. And systematic reviews and meta-analyses have shown no statistical differences between cyanoacrylate and endothermal ablations in terms of the technical success rates. Pain, however, early on with cyanoacrylate may be significantly less, and there may be shorter times for recovery and treatment times with cyanoacrylate as compared to endothermal techniques. On the other hand, there's a rare cases of severe hypersensitivity associated with cyanoacrylate vein occlusion, and a few case reports of late granulomatous reactions. However, these are associated with considerable morbidity. There's a small chance of endovenous glue-induced thrombosis, and it's basically a permanent implant. How about for MoCA? Well, there's this randomized control trial looking at the 3-year data of MoCA versus endothermal ablations in 117 patients, and the occlusion rates associated with MoCA were significantly lower as compared to endothermal ablations, especially with veins greater than 7 millimeters in diameter. The LLAMA trial randomized 150 patients to EVLA or MoCA and had similar low interprocedural pain scores. However, at 1 year, the anatomic occlusion rates associated with MoCA were inferior as compared to EVLA. And another randomized control trial found that both EVLA and MoCA were highly efficacious at 2 years at improving quality of life. The Maradona randomized control trial had 213 patients, where they took patients and randomized them to MoCA or RFA, and found that MoCA had less postoperative pain, but more hyperpigmentation as compared to RFA. They also noted higher anatomic failure rates after MoCA and similar quality of life scores at 1 to 2 years. How about foam? This trial randomized patients to 4 arms with ultrasound-guided foam sclerotherapy, RFA, EVLA, and surgery, and they found that ultrasound-guided foam sclerotherapy had the highest failure rates at 3 years at 26% as compared to RFA, EVLA, and surgery. Other randomized controlled trials have suggested that the initial improvement in quality of life reduced over time and was significantly worse at 5 years after treatment with ultrasound-guided foam sclerotherapy as compared to endothermal ablations. So when would foam be preferred? Well, if the vein you're treating is adjacent to the nerve, that might be preferred to use foam. If the vein is very tortuous, not allowing other techniques to be performed, foam might be advantageous. And of course, there are significant advantages in terms of cost in certain insurances. In certain patients, it may be useful to use foam. And if the vein is very small, if the patient had a good sized vein in the ultrasound room, 5-6 millimeters, and then went to the procedure room and they're quite young, they're nervous, and goes into spasm, foam might be a good option for some of those patients also. So getting back to the original question, when do you use endothermal ablations or non-thermal techniques? And basically it comes down to that non-thermal techniques are made of 3 different techniques, and each one has advantages and disadvantages. The pain scores initially might be better with non-thermal techniques. However, the long-term success with foam is inferior. And therefore, we suggest for patients with symptomatic axial reflux of the greater saphenous vein, we recommend both thermal and non-thermal techniques, depending on the available expertise of the treating physician and the preference of the patient. Each technique has advantages and disadvantages, and the practitioner needs to be familiar with each of those and needs to select what works best in that particular patient, in that particular anatomy, for that particular disease. Thank you.
Thanks very much, Dr. Hingorani. Our next presenter is Arjun Jayaraj from the Rain Center in Jackson, Mississippi. Dr. Jayaraj is a vascular surgeon at the Rain Center, which focuses on the management of venous and lymphatic diseases. He serves as an associate editor on the JVS Venous and Lymphatic Disorders Journal, besides being a member of the editorial board of the JVS CIT and Veins and Lymphatics. Dr. Jayaraj is also on the board of directors of the IAC, International Commission for Vascular Interventional Procedures. His presentation today will be perforating vein ablation in patients with varicose veins, SEEP Class 2. Dr. Jayaraj.
Good evening, everyone. At the outset, I would like to thank the Society for Vascular Surgery for the opportunity to present in this evening's webinar. Thank you. I have no financial disclosures relevant to this talk. Let's consider the scenario of a 38-year-old lady with symptomatic venous varicosities of the left lower extremity. Her symptoms included achy pain as well as itching over the varicosities, and she had tried compression stockings, but they really did not offer much help. Her other history is significant for 3 pregnancies, each of which made her symptoms worse. She had no family history of venous varicosities, and she was a stay-at-home mom. Her BMI was 25. And this is how her varicosities looked like, and you'll notice that they drape around her leg, posterior, lateral, medial, as well as anterior. Duplex ultrasound revealed a great saphenous vein of about 6.8 millimeters in size and a reflex time of 2.5 seconds. But she also had a perforator that was refluxing, and this perforator was 4.4 millimeters and was refluxing for 1.4 seconds, all of which meet criteria for significant reflux. So what should we do for her? If you look at the guidelines, we note that for patients with varicose veins who have significant symptomatic axial reflux of the great or small saphenous vein, the recommendation is against treatment of the incompetent perforator veins concomitant with the initial ablation of the superficial truncal veins. And this is grade 1C. And the evidence comes from a few studies, the first of which is a randomized controlled trial that evaluated 38 patients who underwent high ligation and stripping with staff lobectomies with sepsis versus patients who just underwent high ligation and stripping with staph lobectomies. And they found that there was no significant difference with regards to pain. The visual analogs pain score was used, mobility, cosmetic score, or quality of life between the two groups. A second randomized trial actually compared endovenous laser ablation of incompetent perforator vein in the thigh, followed by ablation of the great saphenous vein below the entry point of the incompetent perforator vein, with just endovenous laser ablation of the entire great saphenous vein starting above the incompetent perforator vein. And they found that there was no significant difference in clinical success between the two groups at 3 months, 6 months, or at 12 months. A third randomized trial actually looked at great saphenous vein stripping and phlebectomy with open ligation of the incompetent perforator vein versus great saphenous vein stripping and phlebectomy only, and that they found there to be no significant difference between the groups in either the preoperative or the postoperative venous function. Study that was a single center prospective study evaluated endovenous laser ablation of refluxing saphenous vein and foam sclerotherapy of venous varicosities with a second group that underwent endovenous laser ablation of the refluxing saphenous vein and foam sclerotherapy of venous varicosities with additional foam sclerotherapy of the incompetent perforator vein. And they found no significant difference in improvement of the venous clinical severity score between the two groups on follow-up at 6 months. And they also found that the improvement in the VAS vein score was greater after treatment of isolated saphenous vein reflux that was statistically significant. So based on this, we decided to pursue endovenous laser ablation of a great saphenous vein with staph lobectomies and left the perforator vein alone. She's approximately 6 months out at this point and is doing well. Now let's consider another scenario. A 69-year-old lady presenting with symptomatic venous varicosities of the right lower extremity. Symptoms included burning pain as well as itching and localized edema. Compression stockings gave us some relief, but she still had significant residual symptoms. She also had no family history of venous varicosities, and her BMI was 33. And this is how her leg looked like, and you'll notice there's significant venous varicosities just below the knee, as well as in the thigh, and she had varicosities in the groin as well. On duplex ultrasound, she was found to have great saphenous vein that was around 4.5 millimeters in diameter, that was refluxing for 5.6 seconds, and she also had a thigh perforator that was 4 millimeters in diameter, and that was refluxing for 6.3 seconds. So in this particular patient, based on the previous recommendations, we decided to proceed with great saphenous vein ablation with staph lobectomies without perforator ablation. However, at 9 months, she came back with recurrent symptomatic varicose veins. So what do we do at this point? Now, if you look at the guideline, in patients with persistent or recurrent symptoms after previous complete ablation of the incompetent superficial truncal veins, the suggestion is to treat the perforator vein incompetence if it is the origin of the symptomatic varicose tributaries, and this is grade 2C based on the quality of evidence. So in this particular patient, her saphenous vein was still closed. However, she continued to have an incompetent perforator vein that was feeding her some recurrent venous varicosities, and so we decided to pursue perforator ablation and staph lobectomies. She's around 7 months out now and is doing well. Thank you.
Thank you, Dr. Jayaraj, for your excellent presentation. As a reminder to our attendees, please use the Q&A button at your screen to submit your questions at any time for any of our presenters. Our final presentation today will be delivered by Dr. Harold Welch, Professor of Surgery at Tufts University School of Medicine. After completing his surgical residency and vascular fellowship at Tufts New England Medical Center in Boston, Dr. Welch served in the US Navy and then spent 3 years at Tufts before moving to the Leahy Clinic, where he practiced for 24 years. After 18 months in private practice on Cape Cod, he's returning to Leahy Clinic now as interim chair of the Department of Vascular Surgery. Dr. Welch is past president of the American Venous Forum. He joins us now with a presentation titled Saphenous Vein Ablation with Concomitant versus Staged Treatment of Varicose Tributaries.
Good evening and thank you. I believe this topic is one of the more controversial issues in the treatment of varicose veins. And like politics, it might be difficult to influence your viewpoint or preference concerning concomitant or staged treatment with saphenous vein ablation. The origins of this controversy likely started almost 20 years ago. Dan Monahan in his 2005 JVS paper reported that 24% of varicose veins resolved completely after RFA with the first generation catheter. And of those that did not resolve totally, 89% decreased in size. He also found that 41% of the limbs treated with RFA of the great saphenous vein did not require further treatment. This was followed up a year later with a paper I wrote published in 2006 in JVS, where 184 RFAs were performed, again with the first generation closure plus catheter. 7 patients had concomitant phlebectomy. Of the remaining 177, there were 101 patients with complete ablation of the great saphenous vein, and of those, 65% had symptom resolution and no further therapy. Well, let's re-examine where we are today and start with a somewhat typical case. This is a 40-year-old woman with bilateral symptomatic lower extremity varicose veins, right worse than left, for 5 years, the onset occurring after pregnancy. She has a strong maternal family history of varicose veins and has the typical symptoms of heaviness, itching, aching, and throbbing, typically on a daily basis, exacerbated by hot weather, exercise, and her menstrual period. She tried compression pantyhose without relief and had a venous reflux study which showed severe reflux in her right great saphenous vein, anterior accessory saphenous vein, as well as on the left great saphenous vein. This is a preoperative photograph showing her thigh varicosities and those medially below the knee. Intraoperatively, she had both her great saphenous and anterior accessory saphenous vein ablated, and she also underwent concomitant phlebectomy of her thigh and below knee varicosities and did very well postoperatively. So this brings us to our first 2 guidelines concerning reflux in the truncal veins and symptomatic varicosities. And the guideline committee recommends for patients with symptomatic reflux in the great or small saphenous vein and associated varicosities, we recommend ablation of the refluxing venous trunk and concomitant phlebectomy or ultrasound-guided foam sclerotherapy of the tributaries. And this is a grade 1C recommendation. And also, for patients with symptomatic reflux in the anterior accessory or posterior accessory saphenous veins, we recommend ablation of the refluxing trunks with concomitant phlebectomy or ultrasound-guided foam sclerotherapy. And this is a grade 2C recommendation. Why do we make those recommendations? Concomitant treatment is usually the more cost-effective approach and is associated with less time off from work. In legs with non-saphenous varicosities, ablation alone will not resolve them, and concomitant treatment would be more appropriate. Harlander-Locke et al. Looked at a retrospective review of 1,000 consecutive radiofrequency ablations, and of those with varicosities greater than 3 millimeters in diameter, 70% had concomitant phlebectomy, and a further 25% had subsequent phlebectomy for symptom resolution. Thus, 95% of patients with varicosities greater than 3 millimeters in diameter underwent phlebectomy. Brown and co-authors examined data from the varicose vein registry and divided patients into ablation alone and ablation plus phlebectomy. While both groups showed improvement in VCSS and typical symptoms, the improvements were better in the ablation plus phlebectomy group. Another report by Conway and co-authors in 2020 utilized data from the American Venous Forum Varicose Vein Registry, and they found that patients who had combined therapy, ablation plus phlebectomy or sclerotherapy, had lower pain scores on the VCSS than ablation alone. Let's look at the other side of the coin, that is staged procedures. For patients with symptomatic reflux in the great or small saphenous vein, we suggest ablation of the refluxing venous trunk and staged or ultrasound-guided foam sclerotherapy of the varicosities only if there are anatomic or medical reasons. We suggest shared decision-making with the patient, and this is a grade 2C recommendation. And likewise, for patients with symptomatic reflux in the anterior accessory or posterior accessory saphenous vein, we suggest ablation of the refluxing venous trunk and stage phlebectomy or ultrasound-guided foam sclerotherapy of the varicosities, again, only if there are anatomical or medical reasons. We suggest shared decision-making with the patient. While the evidence supports concomitant treatment of truncal reflux and symptomatic tributaries, there will be circumstances where a staged approach is appropriate based upon medical or anatomic reasons. These include extensive bilateral or circumferential varicosities, a need for general anesthesia, or large amounts of tumescence or local anesthesia. There may be other reasons based upon patient preference as well, as we all know. The evidence for staging procedures comes from the two studies mentioned earlier from Monahan and Welch. A meta-analysis by Hearn and others showed truncal ablation alone was sufficient treatment for 64% of those assessed. However, they did show that both concomitant and staged treatments were safe and effective, and also that improvements in early disease severity and quality of life scores were better in the concomitant group. Just for consideration, there are hundreds and hundreds of insurance policies dictating how we can treat our patients, including this from Blue Cross Blue Shield of California, where under 1B here states that all saphenous veins in the same leg that meet their criteria for treatment, that is size and reflux, must be treated at the same time. And finally, for those patients who undergo ablation alone, we recommend that patients be followed for at least 3 months to assess the need for stage phlebectomy or ultrasound-guided sclerotherapy to allow adequate time for possible regression or resolution of the tributaries. Thank you for your attention.
Thank you, Dr. Welch, and thanks to all our presenters for the great presentations tonight. I'm asking them, along with our co-moderators, to turn on the cameras and join us for a roundtable discussion. Hopefully everyone has had plenty of time to add your question to the Q&A button, but if not, please feel free to do so now. We received actually a lot of questions, and let me start out first with a question to Dr. Meissner. Dr. Meissner, it seems to me that you favor distal cuff deflation for reflux measurement, but could you assure us that Valsalva or distal manual compression are also acceptable techniques? When should we use those?
Thanks for the question, Peter. You know, and again, it gets back to the supine versus standing position. If you look at patients supine, a paper from our laboratory, Ari Markel in 1994, showed that the sensitivity of Valsalva, even proximally where it's most sensitive, is only about 70%, and it declines distally. Manual cuff deflation or manual compression is most sensitive distally, less sensitive proximally. That's in the supine position. So I think you can throw both of those out in the supine position for a lack of sensitivity and some lack of specificity. That being said, in the upright position, there are several papers out there comparing the two, one by Stavros Kakos, showing that acceptable results were achieved with manual distal compression in comparison to pneumatic cuff compression. So I think you can use manual distal compression in the standing position. That being said, it's very ergonomically unfavorable for your technologists who will probably complain of it. And certainly most technologists, in fact, there was a consensus statement sent to the IAC a few years ago by the SVT suggesting that all labs should have pneumatic cuff deflators because ergonomically it will make your technologist much happier. And as the INVEST study showed, that is the most reproducible way of eliciting reflux. So in conclusion to your question, Peter, acceptable results can be obtained with manual distal compression. Your technologist won't like it, and it will be a little less reproducible.
Thank you very much. I have a question to Andrea Obi from Dr. Jerry Chen. Which technique is the best for epiphyseal great saphenous vein reflux? A thermal or a venosyl, or I am asking you open surgery maybe?
Yeah, I think that's a great question. And I don't think there's an excellent answer for it, just because some of the non-thermal techniques are new and we just don't have a lot of that data completely available to us. I will use either one with an epiphyseal GSV as long as I feel like there is enough of a fat pad basically to prevent hyperpigmentation or paresthesia or feeling of a hard cord in the leg. And so it really just comes down to what insurance will cover and what the patient prefers for their treatment. And there is some data suggesting that there's one site that says if you have about 10 millimeters of tissue over the top of the vein, then that should be adequate for a thermal ablation.
I also have another question to you, Andrea. What is your technique to minimize sural nerve injury during endovenous thermal ablation of the small saphenous vein?
Oh my gosh. Well, I don't know that I have the magic answer to that other than a whole lot of tumescence. The only thing I can say is I start with my tumescence along the sheath itself. So I actually start right where I make the puncture and instill there. And then I go all the way up to the popliteal fossa. And then I rescan and do more if needed. I'm just very cautious. I don't know if anyone else, if Hale or Mark or someone has any other better answer than that.
Anybody else would like to chime in?
No, I agree with Andrea. I try to look on ultrasound to see if you can see the sural nerve and see if you can displace it with the tumescent. But and I also will try to go to the mid calf or mid distal third of the calf.
Thank you. I have a question to Dr. Hingorani from Dr. Majid Aizid. How to treat isolated anterior accessory vein reflux when there is no great saphenous vein reflux? Could you unmute? Could you unmute yourself? You are muted. He's on the phone. Dr. Asher is calling him.
Sorry, can you hear me now?
Yes.
Yes, now we can hear you.
Okay, so as long as the patient's tried conservative therapy, I still think that there's a role for treating the anterior accessory vein, even if there's no reflux in the greater saphenous vein for patients who are anatomically and hemodynamically appropriate for fixing the vein.
But there is reflux. I think that's what the question states, that you have pathologic reflux in the anterior accessory saphenous vein. How do you treat that?
We still suggest that the endothermal ablation is a very good way of treating it. I still think that there's a role for non-thermal techniques also, but I think most of the people would agree with going ahead and treating that with minimally invasive techniques. Again, we don't have very good data, head-to-head data comparing, as Dr. Obi had suggested, stripping versus endovenous techniques. But I think the endovenous techniques still have a very good role to play. Which one of the techniques, we still don't have good data. With the greater saphenous vein, we've already stated, and others have also agreed. A recent Cochrane review also comparing thermal versus non-thermal from August of 2021 also suggested that there may not be much of a difference according to the data that we have today. So for the anterior accessories, the posterior accessory, we even have less data.
All right. Dr. Jayaraj, what is the best technique to treat thigh perforator vein?
Yes, I don't think there is data to suggest that one particular technique is superior to the other. It boils down to the expertise of the physician actually considering the treatment. and also the anatomy of the patient.
All right. Andrea, somebody was wondering why you didn't talk about compression. Does compression has a role in the treatment of varicose veins?
I think that's because you only gave me 6 minutes to answer a question about high ligation and stripping.
SVS.
Compared to all other therapies. Yeah, the question wasn't that I was trying to answer was high ligation stripping compared to other therapies, not does compression have a role? But I mean, there was a recent Cochrane review that came out looking at about 1,000 patients and the utility of compression in treating C2 disease and above. And basically the summary of that Cochrane trial stated that there was insufficient evidence to recommend compression as sort of the standard of care for long-term therapy for superficial vein disease. And the reason is that while it can decrease edema and some of the patient's symptoms, there are issues with patient compliance, and there are other better therapies out there that we know work quite well. So it's certainly a tool in the toolbox for the treatment of patients with superficial vein disease, but we shouldn't necessarily deny patients treatment with interventional therapies that we know work.
That's true. Dr. Welch, why don't you recommend longer follow-up in the guidelines than 3 months for patients after varicose vein interventions? Most specialists would like to see their patients every year at least once.
Well, I think the follow-up can vary. After phlebectomy, I'll typically see patients back in 2 or 3 weeks, see how they're doing. After an ablation, I typically see them within the first 10 days with an ultrasound. And if everything's okay, then I'll see them back at 3 months to reassess their tributaries, if they are, and whether or not they need an intervention. If the tributaries are improved at 3 months, but not totally resolved, I'll see them back in 3 more months, again, to decide whether or not they need an intervention. And I tell my patients with varicose veins, they know where they can find me. They can call me if their symptoms come back or their veins come back. They can come and see me. I think seeing vein patients back every year, they got to take time off from work. They got to pay a copay for us to say, oh, your legs look great, see you in another year. So if they have symptoms or recurrences, then they can come see me.
I think it is important to state to everybody that these guidelines deal with C2 disease, simple varicose veins. And of course, patients who have chronic venous insufficiency, more advanced stages, those are patients who need indeed, recurrent rechecks. But I think most of the guideline authors agreed that patients who have C2 disease should come back after 3 months if they have any symptoms. Dr. Meissner, the insurance companies are asking for diameter measurements, even though you stated that there is no clinical evidence that we should use currently, based on the current data, the size of the vein as a determinant of treatment. But still, if you have a 3 millimeter grade saphenous vein with a reflux that's 600 milliseconds and a few branch varicosity, how do you treat a patient like that?
Well, Peter, kind of as I said in my talk, you can't interpret the duplex scan in a vacuum. What's most important is how the patient's clinically presenting, what their complaints are, what their demographics are, and how that correlates with the duplex examination. And there was a question in the chat about talking about saphenous sparing procedures, and certainly there is pretty good data from Paul Vitaluga and Asphal in patients who meet the criteria of young patients, primarily cosmetic concerns, and never pregnant with a saphenous vein less than 4 millimeters, that those patients do fine with managing their tributaries alone, and that saphenous reflux will reverse in about 60% of the patients. On the other hand, if a patient is presenting with generalized aching heaviness and some appropriate mild ankle swelling with a 3 millimeter vein, I think you have to interpret it in that context as to whether that vein warrants treatment or not. I think in an appropriate context, that is the patient with the appropriate symptoms, I wouldn't necessarily exclude treating the saphenous vein based on size. And the data suggests in the meta-analysis, they very strongly concluded that diameter should not be used as an exclusionary criteria. And I would ask everybody to stay tuned for part 2 of the C2 guidelines, which will have a guideline addressing vein diameter in it.
Thank you. Dr. Jairaj, I have a question here from Dr. Sabalbal, who wants to know if you should treat superficial venous reflux in the presence of a significant deep venous reflux.
Yeah, that's a great question, and that's again something that we are going to explore more in part 2 of the guidelines. The simple answer to that is for patients with C2 disease, we would go ahead and treat the superficial venous reflux and see how they respond with leaving the deep venous reflux alone.
Dr. Meissner, there is a technique on duplex scanning of the nerves. Specifically, Leonardo Randial is asking me if there is a special technique to identify the nerve on ultrasound and use that to protect it from injury.
Well, particularly with the sural nerve, we know the sural nerve generally perforates the muscular fascia at the musculotendinous junction of the gastrocnemius, which can be a rough anatomic landmark. And if you have a good ultrasound, you will be able to see the sural nerve in a fair amount of patients as a very bright echo, 1 to 2 millimeters to the side of the small saphenous vein, and avoid it that way. So oftentimes you can see the sural nerve with ultrasound. If you can't see it, use anatomic landmarks. And for the great saphenous vein, the saphenous nerve anatomy is very variable. In most patients, we know it joins in the proximal third of the calf after perforating it about the adductor canal. But in about 10% of patients, the saphenous nerve will accompany the great saphenous vein from the groin on down. So the anatomy of the saphenous nerve is very variable. And I think everybody who's ever dissected out a saphenous nerve in the calf knows how small some of those fibers are that are intimately intertwined around the saphenous nerve below the knee, and those you can't see with ultrasound. But the sural nerve is fairly accurate to see with ultrasound.
And I have one question to Dr. Hingorani, who talked about foam treatment. Could you amplify that you are talking about physician compounded foam, but not the commercially available microfoam? So there are people who would like to know if the commercially available microfoam is better than the physician compounded foam.
Unfortunately, we have very limited data comparing the two. What little data we have is really would not be able to answer those questions. There are some theoretical advantages to using the commercially available microfoam, but that really doesn't answer the question which one is better. So we only have the data. So we are waiting for more answers, but there is an increasing number of papers that are being published, and many of them in the Journal of Vascular Surgery, Venous and Lymphatic Disorders, about the benefit of the commercially available microfoam. Peter Lawrence, do you have a question to our panel? And why don't you just go ahead with your
question? I've got lots of questions. What I'll do is combine some as I've been looking in the questions and try to do it in a little bit different order so we hear from everyone. Hal Welsh, you talk about concomitant versus staggered therapy, and there in some people who use that commercial foam, it is possible not only to ablate the saphenous vein or small saphenous, but to reflux it into the tributaries. And mine and one question here was, should we be trying to not only close the saphenous vein, but when it's possible to reflux into the tributaries to treat them simultaneously, even with foam?
So I'm going to have to be honest. I don't have experience with commercial foam, but from what I've read, I think that technique to reflux into the tributaries is safe and effective, as long as you monitor the dosage of the foam. So I think that's appropriate when it can be done.
Anybody else have comments on the group?
Yeah, I can talk on that a little bit because I do use foam in my practice, and I find that the two situations in terms of axial reflux and tributary beds and using it where it's very useful is in a refluxing anterior accessory or a distal GSV where the top has been treated already, that are associated with sort of a smaller tributary bed, that usually you can get complete treatment for that patient with just a simple needle stick procedure. And the upper limit of Varithena is 15 cc's, I believe. So if I think I can do that, I think it's a nice one-stop procedure for the patient that's really minimally invasive.
Dr. Jairaj, let me ask you a little bit more about the great saphenous vein and perforators. There are occasionally patients who have no reflux above the knee, but have reflux from the ankle to the knee and may or may not have an incompetent perforator. When you find reflux limited to below knee saphenous vein, do you treat it any differently than if it's above knee?
If the reflux is just confined to below the knee and they have symptomatic venous varicosities that connect to the refluxing saphenous vein, then you can make a case.
And the thigh vein, the thigh saphenous looks completely normal in size and reflux.
So you would treat the below knee refluxing great saphenous vein at the same time you do the staph phlebectomies for the varicose veins below the knee.
And there are a couple of nice little perforators right near there. Would you not be tempted to treat them as well?
No, I would not. No matter how juicy they look, I would leave the perforators alone the first time around.
Okay, so no matter where it is, you don't treat the perforators first.
Not for C2 disease.
First round.
Yes, not for C2 disease.
Dr. Meissner, some patients are asked by vascular lab tech to stand for long periods of time to get more venous reflux and even to do toe raises. And so you talked about the importance of standing. If you were to try to augment the duplex by prolonged standing or toe raises, does that make sense? And is there any validity to doing that?
Well, I can't speak to the toe raises because I'm not familiar with it and haven't seen it done. Certainly prolonged standing, most symptomatic C2 disease is a disease of gravity and prolonged standing. So I don't think there's anything wrong with scanning patients late in the day after they've been up and around when they're most symptomatic. If you're really interested in diameter measurements, but really the only reason I think diameter is important is if you're trying to, obviously if it's a very small diameter saphenous vein, you have to question the validity of the reflux. But more commonly, it's just failure to meet an insurance threshold. And most of the data in the literature suggests that there's very little correlation between symptoms and diameter. So I don't think it's unreasonable in a patient with a 5 millimeter saphenous vein who has appropriate symptoms to examine them late in the day if all you're looking at is diameter. But again, I'll emphasize it again, all of the data in the literature suggests there's no correlation between diameter and quality of life.
So you don't have a clinic where all the patients are standing while waiting to see you before they get their examination?
No, they get their examination when it's convenient for them and when there's an appointment. So we don't purposely do that.
Dr. Obi, there's a couple questions about this, but you talked about anatomic variations close to the skin. So how about a truncal vein, which is huge proximally, maybe even considered aneurysmal? Is there any maximum size where you wouldn't do a procedure, whether it's ablation or foam or sclerotherapy or stripping?
No, maximal size. I mean, I think that it depends on how big it is. So the initial IFU for the RFA, for example, was 12 millimeters. And then a few studies came out suggesting that perhaps you would be safe and have good anatomic closure rates slightly higher. And I think the best data I've seen is up to 18 millimeters. Now, if it's truly aneurysmal at the junction, then I just ligate those patients to remove the risk of any thromboembolism in the future. And then treat thermally below that ligation. And that's not a very morbid procedure to do.
And you do that simultaneously. So you ligate it in the operating room and then pass the catheter from the knee and ablate the vein at the same time?
Yeah, I actually put the catheter in and then put a bunch of tumescence around it and then do the cut down, because the tumescence does the dissection for you. And it's like a 2-second incision, and then get my ties on and finish, and then you can finish the procedure pretty easily. And I honestly don't know. I'm really curious. Maybe Anil knows the answers to maximal size for the non-thermals. I mean, I do use non-thermals in my practice, but I haven't used them on a particularly large saphenous vein. And I think that's a great question.
We've been reluctant to use it for huge with commercial foam with Varithena. We've been very reluctant to do it when you get an enormous proximal saphenous vein. But
yeah, I limit my Varithena use above the knee. And I know people have different practice patterns, but I do worry about that large thigh perforator. So I often favor, a different thermal or non-thermal technique.
Dr. Hingarani, there's a question here which is sort of similar to a question I had about how you treat a very large tortuous interaccessory saphenous vein. And in the quite Q&A, it often is true that the interaccessory saphenous vein, the straight part of it is very short. The question is, do you ablate that? And what do you do about the tortuous part of it? And do you do it simultaneously or do you do it concomitantly?
So that portion, we will usually try to go ahead and try to use some type of endothermal technique, even if it's short. Let's say it's 10 centimeters or less. In theory, hopefully that would be the main source of reflux to that remainder of the tortuous segment. If it's very, very superficial and very large distally, I have found that sometimes you may need to actually fix those veins also and do a staphyloidectomy if it's very close to the skin, as some of those patients often are with those anterior accessory veins that are quite large after that straight portion. So sometimes I would consider doing a combination.
Okay. I think, sorry, Dr. Watson, I think, why don't you go ahead? We've got about 20 minutes left and each of us have taken 15 minutes of questions, and then we'll have 5 at the very end if there are new ones that have come up.
Great, thank you, Dr. Lawrence. So Mark, Dr. Meisner, one of the things that we look at in the lab is the velocity of reflux. And there's some, I think, studies that show you want it at least 20 centimeters a second, rather than just the actual reflux time. What are your thoughts about that?
Well, the only paper that I really know that has much validity is Bill Marsden's paper looking at velocity in the popliteal vein, where at least in the popliteal vein, it does seem to have some correlation with more advanced venous disease. But in the saphenous vein, I think the data has been all over the place, but I think most of the data suggests that there is not a clear correlation of velocity either with the patients presenting symptoms or with outcomes. And, a couple ways to think about it, which is worse, short duration, high velocity reflux or long duration, low velocity reflux. And I don't think there's a lot of convincing data one way or the other, in that particularly the low velocity prolonged reflux probably is most related to the size of the variceal reservoir. That is, if you have a lot of varices that are filling from a refluxing saphenous vein, it's likely to be lower velocity and much more prolonged. So I don't think there's a clearly established role at the current time for measurement of velocities. It's just too variable, and there's too many determinants of what the velocity is.
Yeah, and I think it's controversial, but and before I forget, just a follow up to Dr. Lawrence's question about your clinic full of standing patients. You know, we will also tell our patients not to wear their compression socks. So this may be more experiential than data driven. What's your feeling about telling them not to wear their socks the day of the duplex?
You know, I guess I would prefer to scan them when they're, you know, at the end of the day, this is a symptom and quality of life driven disease mostly, and I'd like them to be scanned optimally in the situation that they're most symptomatic in. And if, you know, if they're not wearing stockings and they're symptomatic and aren't going to wear stockings, that's fine not to wear stockings. On the other hand, if their symptoms are pretty well controlled with stockings, but not completely, I think it's fine to wear stockings. So I'm not real compulsive about that.
Thank you. So Andrew, there's a question here from one of the attendees about a patient who has a remote history of saphenous ligation, and now they have recurrence of reflux. I would assume that's either at the junction or maybe throughout segments of the GSV. Is that something that you would tackle? I don't want to get into the issue too much of neovascularization, but how would you approach that?
That's a great question. And I think I typed in an answer, but maybe I didn't answer it completely the right way. So if someone's had a high ligation and stripping, they have varicosities, the first thing that I do is go back to the drawing board. So get them a full venous mapping, map the tributary bed, map the axial veins, and find the source of reflux and really focus on treating that. Sometimes it could be a GSV that's either recanalized or recurrent. It could be an anterior accessory, or it could be a perforator. But once you've sort of localized the source, then you just treat it in the most common sense way possible. So if it's an axial vein, I'll often go to an endovenous treatment. Whichever one makes sense. I will use some adjuncts if I think it's going to be a difficult one to get, for instance, an RFA catheter in or something. I might use a wire, or if it looks small in places, then I might use foam. So just, you sort of have to use your best judgment there. If it's a perforator that seems to be the source of the recurrent varicosities, then I often do stabs to take care of the varicosities and then just ligate that during the course of the stab phlebectomies. But I don't know, there's a bunch of other people on this call that may have a different approach to that as well.
Thank you. Arjun, I'm going to throw one to you about, you talked about when to do perforators, but did you come across any studies in terms of what's more effective? There's been an RFA catheter that's sort of come and gone, the EVLT as well as foam. Do you have any thoughts, or is there any data on that?
No, there's no data in terms of one technique being superior to the other. I mean, different kinds, open has been tried, sepsis has been tried, as you said, RFA, laser, non-thermal techniques. And so I think, it all comes down to, like I said in a previous answer, to the expertise of the particular person at treating the disease. And so whatever he or she is comfortable with should be the modality of treatment.
Great.
Excuse me, Dr. Watson. I'm sorry. I just want to, before you continue the discussion, I want to alert the attendees that we will launch the post-event survey now. So as with the pre-test, attendees will need to scroll through all of the questions, and they will only be able to click the submit button after they answer all of the questions. We'll compile the results as soon as all of the attendees have completed the test. And this will also be followed with a final survey 60 days from now to gauge and evaluate if the guidelines were easy to translate into daily clinical practice. Thank you.
Thank you so much, Pete. So Dr. Welch, it's been a little bit frustrating in terms of the staged phlebectomy and foam versus concomitant session. I remember not too long ago where you had to repeat the duplex scan at 6 weeks before you could attempt foam after an ablation. And then, and as you have pointed out, in some insurance companies, they won't pay for it on the West Coast unless you do it in the same session. I find that we can reduce our number of foam sessions if we wait a little bit time after the ablation before doing the tributaries. But you've done this a long time. What is your experience with that? Which way do you favor?
Well, that's interesting. I started out obviously as a staged person, along with Dan Monahan. I've lots of conversations with him. And more recently, it's probably 50-50. It depends on the patient. And Dan Monahan and I have had a number of discussions on this, and we feel it's how the provider sells it to the patient. If you tell a patient that 80% of the time your symptoms will improve with an ablation alone, they'll probably go with that. If you tell them I can cure all your varicose veins in one sitting and you'll be fine, they'll go with that. So I think you have to have a thorough discussion with the patient, explain both options, both techniques, and decide, because there's a lot of mitigating factors on what the patient's going to decide. So it turns, and actually, Dan Monahan and I years ago performed we had a follow-up study, a little poster at the American Venous Forum, 700 patients of ours followed up 4 to 7 years later. And basically we asked, what did you prefer? Have them all done at once or would you stage it? And the answer was 50-50 right down the line. Do it all at once versus staged. So goes both ways. Depends on the patient.
Need a study, that's right. Anil, that next question for you. You know, that everything is evolving with time in these studies. And, you know, initially foam was compared to ablation as a single truncal vein treatment, but it seems now more common that we're using foam as an adjunct. When you were reviewing the literature, is it more foam for truncal vein versus EVLT or RF, or was it a combination of both that was being compared? Because I think that makes a difference in the results.
So the literature that we looked at was looking at the greater saphenous vein treatments. We really, in our section, did not look at foam for the tributaries. So we limited the use of the studies that we examined for treatment of the greater saphenous vein, short saphenous vein, accessory veins, et cetera, only.
Yeah, and I think the literature has a hard time keeping up with what we do in practice. And again, in terms of evolution, there's been a lot of evolution in EVLT and wavelength. Andrea, when you were looking, your group was looking at this, I bet there was quite a bit of diversity in what wavelengths were used for EVLA. Do you have thoughts about using the older versus like the 1420 wavelength in terms of treating truncal veins?
Yeah, I think that's a great question. You know, for the meta-analysis, we just sort of collapsed all the therapies into big buckets, RFA versus EVLA versus foam, et cetera. So you can't parse that out in the meta-analysis that was done as the basis for this, for these set of guidelines. But I think the consistent trend in what's reported in the literature is two things. So one is there are, I think now 4 different wavelengths reported for EVLA. The bigger the number, the less the pain. So the higher the wavelength, the less pain is reported. At least that's sort of what the trend seems to be. And then the other component that can induce pain is the type of tip on the fiber. And so bare tip is associated with more pain. And there's 3 other tips of various configurations. But my understanding is with the bare tip, you get more perforations, and that's what drives the postoperative pain. Having said that, I use laser mostly for perforators. It's not the main component to my axial practice.
Great, that's really helpful. I think, again, this whole area of what to use is evolving. Mark, there's a question from one of the attendees about evaluating the nerve when it's close to the vein. They asked, what is the best technique to evaluate the nerve that is close? Are there any special things that you have your sonographers look for, or you do when you're performing these procedures?
I don't have the technologists in general look for it. The only real nerve studies our technologists do is specifically looking for sciatic varices, and that's more a question of identifying varices within the nerve rather than identifying a nerve associated with an axial vein. The sural nerve is certainly the easiest to see, and I don't have the technologist look for it at all, but I just do it if I'm doing a small saphenous ablation. When I'm looking for the puncture site, I try to figure out where the nerve is using ultrasound, and it's something that with experience, most of the time you can do yourself with ultrasound at the time you're doing the procedure.
Thank you. There's another one here. I thought this was a great question about GSV reflux that may be above and below the knee. I guess I'll ask Anil, would you do the above knee first with ablation, wait and see how the patient does, and then do the below knee? Or would you go ahead and put in and do both of them?
We tend to treat the above knee segment first and then wait and see how they do. We found that some of these patients with just treating the above knee segment don't need any intervention for the below knee segment, especially for C. On the other hand, for more advanced disease such as C6 disease, we tend to be much more aggressive because we have some retrospective data suggesting that if you're not aggressive with the below knee segment in those patients, they tend to continue to have problems.
Very good. There's a number of really great questions in the chat that you'll stay tuned. We'll keep you on the edge of your seats that we will be discussing and doing in part 2. I'm going to throw it back to you, Dr. Glowicki, to see if there's any other final questions that you would like to ask.
Thank you, Suman. It was a real nice discussion. Some of the issues are obviously controversial, and the guidelines don't answer all the questions. There are a couple of good questions. There are many questions. We received many questions. One, Andrea, to you is, what about elastic versus non-elastic compression? Which is the one that you prefer and why?
So for post-procedure therapy, I think inelastic compression, it offers a better result. We had a whole international compression club about this topic many years ago. I don't know how relevant the data still is, but the overall summary of that was that inelastic compression offers more uniform compression. And the thought is that when patients get up and walk, that we can provide that to the leg and reduce the risk of hematoma and bruising. So I use that for my big phlebistomies.
Peter, could I ask how Welsh to expand a little bit? Because I think that the fact that you've changed your position in 50-50 and whatever suggests, one of the things we do is I base it, whether I do it concomitantly or not, on the size of the vein. And if I have tributary veins in the calf that are, a little bit big, but they're pretty small, then I just suggest that they have a single procedure with ablation of the saphenous vein, because I think they're going to get better, the majority of them. Whereas if they have huge calf veins, then I think even if they get smaller, they're still not going to be happy. Maybe I live in California where cosmetics are so critical, but I would just tell you that patients who have huge veins, they want to have them taken care of. So that for cosmetic reasons. Have you considered basing the staging on the size of the tributaries?
I consider based on a lot of things. The anatomy, certainly if they're medial below the knee and they directly come off the great saphenous vein and they're not too large, I think those patients may have a good chance of resolving their varicosities with just an ablation. I agree if they're very large, those aren't going to get better, they're not going to go away. And so I agree with you, I'll tell the patients that. Or if they're in an anatomic location that's, they're not directly off the saphenous vein, and they may be traveling a distance or they don't want to come back for another procedure, then I'll do it concomitant. So I think a lot of factors come into play, and size is one of them.
You mentioned how the insurance companies frequently want concomitant procedure. Is simply the patient's preference enough to convince them that, for instance, the patient wants a staged procedure? Is it going to be reimbursed?
Well, that's a great question. And as we all know, insurance companies' policies on venous disease has no basis of evidence. So, there are a lot of patients, as we just discussed, that want the procedure done. They have pain and discomfort. And if many of those can get relief simply by an ablation and they don't care about their appearance of the varicosities, then I think it's appropriate to stage those patients and see how they do. So to answer your question, yes, insurance companies should consider the patient's preference.
And I'm going to finish these questions. We have so many questions and we will try to answer you all in writing, but there is one question, Mark, on varicose veins of pelvic origin. Do you treat the pelvic varicosities, or do you investigate the pelvis in these patients, or how do you deal with that?
Well, if they are of pelvic origin, I tend to investigate the pelvis just to know how big the variceal bed is around the uterus. And I don't treat necessarily if a patient has no pelvic symptoms, I don't treat their gonadal vein reflux or their iliac stenosis or whatever the etiology of it may be. But I will treat the varicose bed, and we do that in the office in our OBL, and just do a direct puncture under ultrasound of the pelvic escape point, whether that's in the perineal point or a gluteal escape point or an inguinal escape point. We'll just do a direct puncture under ultrasound, calibrate the volume of the variceal bed, and frequently you can reflux contrast all the way from a pelvic escape point up into the ovarian veins. From a direct puncture, and then I'll treat that with foam, and I'll calibrate the volume, mix the foam with some contrast, and inject that volume following the contrast with fluoroscopy, and then I'll treat the distal varices with phlebectomy or foam or whatever the choice is. So I do evaluate them with ultrasound. I do treat the periuterine and periovarian varices, but not from above, treat it from below, which is foam.
Thank you very much. I think this has been a very interesting and useful discussion. Before we close this webinar, I'd like to remind our attendees once again that we will be closing the survey very shortly. So please complete that now if you haven't already done so. I'd like to once again thank our presenters this evening, Doctors Mark Meissner, Andrea Obi, Anil Hingorani, Arjun Jairaj, and Harold Welch. I would also like to thank my co-moderators, Doctors Peter Lawrence and Suman Vasan. And to our attendees, thank you for participating in the guideline session tonight. You will also receive a final survey 60 days from now to gauge and evaluate if the guidelines were easy to translate into your daily clinical practice. Today's webinar has been recorded and will be available on the SVF's website in 2 weeks. Thank you again for joining us.